Dedicated lectures I took almost 20 years ago. As professor, head of department of surgery, I belong to 1959 batch of Government Medical College. I did my undergraduate and post-graduation both there. I held all posts, right from house officer, registrar, graduate medical officer, lecturer, reader, associate professor, and finally dean. Even as a dean, I taught. When I was promoted on a joint director's post as OST, I took a voluntary retirement because it was a totally administrative post. And I joined IGMC on 1st of February 1997 after my retirement. For a few years, I took dedicated lectures there also. When I completed 65, I was checked out. After that, I joined PDMC for some time, then Mumbai MMG College for some time as a member of their management council, but there also I taught. But dedicated lectures were never there. I'm so happy to be here. I was told to talk on GI tract, and GI tract begins with stomach. Whenever I start a lecture, you must know your organ first. What I mean by organ here, your organ here is stomach. Unless you know the anatomy and physiology, it is difficult to understand the disease process, its progression, its investigations, its management and prognosis. I strongly believe that anatomy and physiology, whenever needed, is absolutely essential. Therefore, today's lecture is dedicated to anatomy and physiology of stomach. Stomach is a part of foregut. It starts at esophagogastric junction, which is situated somewhere around T10. Esophagus implants or inserts itself obliquely into the stomach, producing esophagogastric junction or GE junction. From there, the fundus of the stomach expands upward like a pouch to touch the left lobe of diaphragm. There are two curvatures of the stomach, the lesser and the greater. Lesser curvature starts at cardia and ends at pylorus, short, curved. The greater curvature is large, out pouches from fundus down, touching the colon, and ends, both the curvatures end in pyloric canal, which terminates into pyloric sphincter. The esophagogastric junction is not guarded by an anatomical sphincter, but there is a physiological sphincter which allows the food to come but does not allow food to go back into the esophagus. This function is because of oblique insertion of esophagus, and the angle which the left edge of esophagus creates with uprising fundus called as angle of His. The spelling is HIS, but it is not pronounced as his. This angle is made more acute. A few fibers of muscles right crust of diaphragm. The fundus expands, forms a greater curvature. After that, the stomach is divided into fundus. You draw a line from G junction horizontally till it touches the critical curvature. The upper part is called as fundus. The lower part is called as body. The lesser curvature, lower down, turns abruptly to the right. That point is called as incisura angularis. A line drawn from incisura angularis to the greater curvature ends the body of stomach. From there starts the pyloric canal. Pyloric canal is narrower portion, ultimately terminates, starts the antrum, not pyloric. Antrum ends into pyloric canal ends into pylorus. Pylorus is guarded by a anatomical as well as physiological sphincter. Body of the stomach forms about 60-65%. Antrum forms about 25-30% of the pyloric canal is narrow. Stomach is totally intraperitoneal. The two layers of peritoneum which join at the hilum of liver form a gastrohepatic momentum. The gastrohepatic momentum at lesser curvature divides to engulf the entire stomach to reunite at greater curvature to form the gastrocolic momentum. Gastrocolic momentum runs on the transverse mesocolon downwards till the middle of the abdomen and turns back as two layers to come to transverse colon, engulfs transverse colon, and these two layers form transverse mesocolon to be attached on the posterior wall of the abdomen. So, greater momentum has four layers. Stomach is totally intraperitoneal. The blood supply of stomach, it's richly supplied, very rich supply. Since it is derived from stomach, the artery of foregut is celiac axis. Celiac axis is a blunt, short vessel arising from front of aorta and gives three branches. The first is left hepatic, which turns up and then runs along the lesser curvature. The second is splenic, which runs transversely towards the spleen, parallel to upper border of pancreas. And the third is hepatic, which gives two branches before it enters liver. The one first is called as right gastric, which turns towards the lesser curvature to ultimately anastomose with left gastric. A second is gastroduodenal. Gastroduodenal divides into superior pancreaduodenal and right gastroepiploic. Right gastroepiploic goes into the greater curvature. A splenic artery at the outer border of stomach gives left gastroepiploic, which runs down the greater curvature. Where left gastroepiploic and right gastroepiploic form an arborization along the greater curvature. Beyond that, splenic also gives short gastric vessels. They are also called as vasa brevia, which supply the stomach. Apart from these four vessels, there is supply from phrenic also. The veins run along the arteries. This forms the right gastroepiploic. All of the veins drain into portal vein. The arteriovenous circulation of stomach is so rich. The arborization is so rich. The applied importance of this is, number one, you can ligate two vessels supplying the stomach safely in an operation of gastrectomy without jeopardizing the blood sample of the residual stomach. In a patient who is bleeding from stomach, when a question of intervention or radiology comes for embolization, you need to minimum embolize two vessels before you can stop the bleeding. Third is the rich arborization of venous system in the blood, in the circulation. You can easily decompress esophageal varices by joining the splenic vein to the renal vein, effective lienorenal shunt. Greater gastrectomy, radical gastrectomy or subtotal gastrectomy, a small fundic pouch, here where you ligate all four pedicles. Even then the fundic pouch sustains itself because of few vasa brevia which must leave in greater momentum and supply from the phrenic vessels. Lymphatic drainage. Lymphatic gain, there is a rich plexus of lymphatics in the stomach. For the purpose of explaining, you can draw a vertical line parallel to both the curvatures of stomach and a horizontal line between them, dividing stomach into four parts. The upper and outer quadrant is drained into lymph nodes placed along the left gastroepiploic vessels. The right upper one is drained in the right gastroepiploic lymph nodes placed along the left gastric. The lower left is drained to the right gastric lymph nodes. The left outer is drained into left gastrophilic lymph nodes placed along the stomach. Most of the lymph nodes are placed along the curvatures of stomach. There are prepyloric lymph nodes. There are cardiac lymph nodes. This is the first station of lymph nodes. The second station of lymph nodes is along the lesser omentum, superior border of pancreas, along the splenic hilum. All these lymph nodes ultimately drain into the lymph nodes situated at the origin of celiac artery. They are called as celiac lymph nodes. They are practically pre-aortic or para-aortic lymph nodes. Such lymphatic network in submucosa, intermuscular, subserosal. The importance of knowing this is, number one, the malignancy spreads much beyond its visible and palpable limits along these lymphatics to involve stomach in up and down along below and above the malignancy. Therefore, in an operation of gastrectomy, when you want a clearance, minimum 5 centimeters stomach on either side must be excised to stop the residual malignant cells being trapped by lymphatic cells in the wall of stomach. Number two, though the metastases are known in the first group of lymph nodes routinely or regularly, this lymphatic arborization sometimes leads to spread of a lymph node much away from a site of malignancy. One must be aware of this fact in an operation. This can be judged on CT scan, but at time of operation, the surgeon must be aware that sometimes a lymph node much away from the site of primary can be involved, which modifies the operation of gastrectomy. Nerve supply. Stomach has both sympathetic as well as parasympathetic. Parasympathetic nerve supply comes from vagus. In thorax, vagus divides into two branches, descends through the esophageal hiatus. The right one becomes posterior, the left one becomes anterior. The anterior vagus gives hepatic branch, the left vagus gives celiac branch. After that, both descend along the greater and lesser courageous stomach. The branch which is given to splenic by the left gastric artery is sometimes called as criminal nerve or Grassi. In an operation of selective vagotomy, this nerve is missed, leading to recurrence of acidity. The left vagus or anterior vagus, which descends along the lesser curvature of stomach in the lesser omentum, gives series of horizontal nerves from below cardia down to incisura angularis. These nerves are called as nerves of Latrechet. These nerves are the ones which were tackled in an operation of highly selective vagotomy. This right vagus ends at the pylorus into multiple branches supplying the antrum and pylorus. Is also called as crowfoot because of patterned branching. The left vagus runs along the gutter curvature of stomach and supplies the splanchnic or splanchnic motor system. The adrenergic vagus nerve is responsible for secretion, is responsible for motility, is responsible for controlling mucosal or submucosal blood flow, is responsible for appetite, it's responsible for cytoprotection of the mucous membrane. The exact function of adrenergic system is not known. The vagal system is cholinergic and secretes acetylcholine as the effective substance. Sympathetic nervous system secretes adrenaline, but the role of which has not been defined yet in stomach physiology. Then comes the wall. The wall of the stomach, starting from inside, is mucosa, lamina propria, submucosa, muscularis mucosae, then muscle mass, the muscle layer, and the outermost is serosa. The mucosa is predominantly lined by columnar glandular epithelium. All throughout, there are glands in the mucosa, tubular glands, which run deep down into right up to the muscular mucosae. These glands predominantly are lined by mucus-secreting cells. And the beauty of these cells is they also contain carbonic anhydrous to produce bicarbonate, and mucus and bicarbonate together are responsible for cytoprotection of the stomach. These tubules of glands have, apart from mucus-secreting cells and carbonic anhydride or bicarbonate secreting cells, have other 5 named cells. Number 1 is parietal cell. Number 2 is Schiff cell, or they are also called as zymogen cells. Third is electrochromaffin-like cells. Fourth is G cell, and fifth is D cell. Parietal cell secretes hydrochloric acid. Schiff cell secretes pepsinogen 1 and pepsinogen 2, mainly pepsinogen 1. Electrochromaffin cells secrete histamine. Somatostatin cells secrete D. D cells secrete somatostatin, and G cells secretes gastrin. The population of these cells, stomach and body of the stomach and fundus has plenty of parietal cells. These tubules of the glands are lined by these cells at various intervals as the need may be. When you go down, the glandular epithelium, the branching of glands become shallow. Majority of cells are G cells and D cells. Is the parietal cells and zymogen cells become less in gastrin. After the mucosa, all cells are sensitive to vagal supply. Submucosa is rich in lymphatic blood supply. The cells are situated on the layer called as lamina propria. Beyond that is a plexus of nerves, vessels, and lymphatic. Beyond that is muscular mucosae. The submucosa descends right down to muscular mucosae. Then comes muscular wall. Muscular wall consists of 3 layers: the longitudinal, the circular, and the oblique. Oblique is situated in the middle. Circular layer ends at the pylorus in forming a distinct anatomical histologic pyloric sphincter. This layer goes on the esophagus without condensation. Stomach is the only organ which has in the GI tract which has oblique musculature also, possibly because its mode of contraction and relaxation for grinding and milling of the food. The last layer is serosa, a very important layer as far as protection of anastomosis is concerned. Physiology of the stomach. The stomach has, I should have said initially, stomach has digestive function, secretory function, motility, it controls appetite, and intrinsic factor controls B12. This is the only organ which secretes intrinsic factor, and therefore total gastrectomies or partial gastrectomies, people need supplement of B12. Physiology of stomach. Stomach is a storage organ, has basically 2 functions, secretory and motor, both mediated by vagus. Secretory function secretes acid, secretes gastrin secretes mucus, bicarbonates, intrinsic factor. The motility is controlled by vagus. The control, there is initial relaxation of stomach after taking meal, then a controlled contraction of stomach, leading to gradual emptying of stomach. The beauty is, before I talk, I think I should talk on acid production. Here, acid production is by parietal cells, which are plenty, about 1 billion parietal cells in the stomach. They are stimulated by vagus. They are stimulated by contact of food with the stomach. They are also stimulated by histamine. In secretion of stomach, there are 3 phases. The first is psychologic, it's also called as. Second is gastric phase, and third is intestinal phase. The first phase is related to your hunger, smell, or the place which incites you to eat something. This is mediated totally through vagus and is responsible for less than 20% of secretion of acid. When you ingest the food, the gastric phase starts. The gastric phase starts where the stimulation of parietal cells is not only by contact with the food coming in contact with electrochemical cells, chlorophyll cells, leads to stimulation of histamine receptors. Histamine release leads to gastric stimulation. This goes on till the pH drops to 1.5. Then the zymogen cells or Schiff cells are stimulated to produce pepsin. Pepsinogen 1 is the one which is more active. It's stimulated when the pH comes down to 2.5, and it stops when the pH rises to 5. This is an automatic mechanism. When the stomach empties, food goes down, the somatostatin D cells are stimulated when the pH becomes high to secrete alkaline secretions. The entire process is controlled by motility of stomach. When you eat food for some time, there is a passive relaxation of stomach to store the food. Then there is a tonic contraction of fundus and body. The pyloric enteral peristalsis, small enteral peristalsis go to the pylorus. A pylorus does not open. This wonderful mechanism is responsible for throwing small quantities of food into the duodenum so that the emptying is regulated. This mechanism of coordination between enteral peristalsis and opening of duodenum is lost in an operation whenever you bypass this junction or excise the junction, leading to problems and complications. Stomach motility is responsible for storage, grinding, milling, milking, and producing a chyme which ultimately is thrown into the duodenum. The third phase, interphase of gastric secretion, is not very clear, possibly related to release of cholecystokinin by duodenal mucosa, which secretes alkaline, stimulates the pancreas and bile to produce more alkaline fluid, reduces the pH, and therefore in turn also depresses the stomach secretion. After the stomach is empty, this is called as resting phase or interprandial rest. This is also controlled by vagus. the entire anatomy and physiology of stomach, all operations, their complications are based on anatomy and physiology. I thought this was important, therefore, first lecture I dedicated to anatomy and physiology.